Okay, hello everyone, welcome back. I hope you're doing well. So today, inshallah, we'll be discussing the 8th lecture in our pharmacology subject, which is about local anesthesia or التخدير الموضعي. Hopefully it's going to be a very easy and very fun lecture, so let's get right into it. First of all, like always, we'll start with some definitions. What is local anesthesia أو التخدير الموضعي؟ من اسمه التخدير الموضعي is a loss of sensation in a circumscribed area, meaning that a very specific area of the body loses sensation because of a specific medication that we are giving. هذا هو التخدير الموضعي. احنا بنخدر منطقة معينة من الجسم فقط من نزيل الإحساس من هاي المنطقة بدون ما نشيل الإحساس من الجسم بشكل عام. This is called local anesthesia. It's a loss of sensation in a circumscribed area. Now, this loss of sensation happens because of a depression of nerve endings. The reason why we feel things like pain or touch or pressure is because of these sensory nerve endings. If we are able to depress these nerve endings, then we are going to cause local anesthesia. And also by inhibition of conduction, because we know that these sensory impulses have to travel to the central nervous system for us to actually interpret these sensations. By inhibiting the conduction of these signals to the central nervous system, we can also cause local anesthesia. Now, one thing about local anesthesia and what differentiates it from general anesthesia is that there is no loss of consciousness. The patient is awake and conscious, and they can respond to commands and they can move, so there is no loss of consciousness, unlike general anesthesia. And of course, it works at a localized area, so it doesn't cause general loss of sensation of the entire body. No. It only causes loss of sensation in a specific localized area that we choose. Now, why do we need local anesthesia? I'm sure most of us know why. It's used in many medical operations. Well, why do we use it in these operations? Because many medical operations and surgeries, they come with fear and pain. الخوف والألم. These two stress factors, fear and pain of the patient, they interfere with our medical operations and surgeries, and they make them more difficult, and they increase risk of complication, and they make the entire procedure very painful for the patient. For that reason, we use local anesthesia to remove fear and to remove pain so that we will have a more successful operation. That's why we use local anesthesia in the management of cuts or the management of burns or even in dental procedures. I'm sure most of you are aware that local anesthesia is very heavily used in the dentistry office for many things like root canals and removal of teeth, etc., etc. So the reason why we use local anesthesia is to, number one, ensure a successful treatment. The fear and the pain of the patient is going to make them very agitated, which will make the operation much more difficult. Using local anesthesia will definitely enhance the chances of success of the treatments. Secondly, is to increase the patient's compliance, because certain procedures require the patient to be compliant and to be conscious and to respond to commands. Using local anesthesia, we are making sure that the patient is actually able to cooperate with their physician, إنه بيقدر يتجاوب ويتعاون مع الدكتور اللي بيعمل عليه العملية، لأنه بعض الإجراءات بتحتاج هذا الإشي. And finally, we use local anesthesia because it allows us to reach a trusting relationship between the patient and the physician. When the patient knows that the doctor is going to operate without causing pain, then they can trust their physician even more, which will again increase the chances of success. But these are the reasons why we use local anesthesia. So how does it work? Just like we said, pain, which is the main thing we're trying to prevent by local anesthesia, is a sensory impulse. Just like temperature and just like pressure, all of these are sensory impulses. And the way that they work is they are basically perceived in the peripheral parts of the body, for example, in our arms and hands and legs, and they are conducted towards the central nervous system via the peripheral sensory neurons. Here we have the site of stimulus, and of course, once we feel pain in that area, we will have sensory impulses traveling through peripheral neurons into the central nervous system. What happens then? These impulses will be interpreted in the central nervous system, and then we will have motor orders sent towards the peripheral organs. For example, to move our arms or legs or anything like that, right? So here we have the motor orders being sent via these motor neurons into the different organs. And yeah, these are called motor neurons. Now, local anesthetics and the way that they work is they block nerve conduction of sensory impulses. We want to affect this part of the sensory cycle. We don't want to affect this part. احنا ما لنا دخل بالموتر. We still want the patient to move. ولكن what we want to prevent is we don't want the patient to feel any pain. So we're going to focus on this part only. This is where local anesthetics are going to work most of the time. We want them to prevent the conduction of any pain signals. Not just pain, but literally all sensory impulses from a specific area to the brain so that we can operate with comfort and we can operate without causing pain to the patient. But this is why we use local anesthetics. Now, granted, in higher concentrations, if we use very high concentrations of local anesthetic, eventually it will start affecting the motor part of this cycle. But for that reason, we have to be careful. We have to choose the correct doses because eventually motor impulses could also be blocked, as you can see right over here, at high concentrations. Now, of course, how do we prevent the passage of impulses to the central nervous system? By inhibiting the depolarization step. We know that impulses or sensory impulses are action potentials. They travel from the peripheral parts of the body to the central nervous system. And in order to prevent this from happening, we have to prevent an action potential from occurring in the first place. How do we do this? By preventing depolarization, because it's the first step of any action potential. When we inhibit depolarization, we prevent action potentials, and so we prevent sensory impulses from traveling, and so we prevent sensations of pain. And so how do we do this? How do we inhibit depolarization? By inhibiting the voltage-gated sodium channels, which are the main mechanism by which depolarization happens. These channels open, allow sodium to enter into the neurons, and they cause an action potential. By blocking or inhibiting these voltage-gated sodium channels, we're inhibiting depolarization, so no action potential takes place. Okay? So when is local anesthesia useful? Do we use local anesthesia in all and every single operation? لا. We only use it in specific operations that have certain criteria. For example, we use it in minor surgeries, يعني العمليات الجراحية البسيطة, where general anesthesia is not needed. Or in quick outpatient procedures. شو يعني outpatient procedures? There's two types of general patient care. في عنا outpatient care والinpatient care. Outpatient care means that the patient goes to the hospital or clinic or whatever, they get treated and they leave the same day. يعني ما بيناموا بالمستشفى. بيروح بتعالج وبروح على داره بنفس اليوم. بينما ال inpatient care اللي هو ال patients they go to the hospital, they get treated and they stay overnight. يعني بيناموا بالمستشفى. وشو ما كانت مدة النوم سواء كانت يوم أو أسبوع، أهم إشي إنه بيضلوا بالمستشفى ليلة كاملة أو أكثر. فبنسميها inpatient. فال outpatient procedures العمليات السهلة اللي هي البيشنت بروح بتعالج وبيروح بنفس اليوم، local anesthesia بيكون فيها جدا مفيد. And of course, we use local anesthesia when unconsciousness and muscle relaxation are not needed. يعني عملية بسيطة ما بدها إنه البيشنت يكون مغمى وما بدنا البيشنت يكون عنده muscle relaxation، بنستخدم اللوكال anesthesia عشان نسهل الوضع علينا. Examples of these procedures include dental surgery or any kind of dental operation. For example, this root canal operation اللي هو سحب العصب. This is one example of when local anesthesia is very useful. Or the removal of a verruca, mole or cataract اللي هي الثالولة أو الشامات أو الكاتاراكت اللي هي المي البيضاء. This is an ophthalmic procedure. And biopsies اللي هي الخزعات. These are also very quick. They're sometimes painful, so local anesthetics can be useful in this case. What are the advantages of using local anesthetics? And when I say advantages, I mean in comparison to general anesthesia. The major advantage here is that there's a loss of sensation without a loss of consciousness. يعني زي ما حكينا في عمليات بتكون جدا قصيرة وما بدنا ننوم البيشنت ونخليه يصحى اليوم الثاني، لا على طول على السريع بنخدر المنطقة بنعمل العملية وبنقول للبيشنت مع السلامة. But that's the major advantage, and there is no loss of consciousness, but there is only a loss of sensation. This is very useful. ثاني إشي there's a sustained ability of the patient to cooperate، يعني البيشنت بيقدر يتجاوب ويتعاون مع الفيزيشن which is very important in some procedures. ثالث إشي there's a low rate of complications على عكس الجنرال أنستيزيا لأنها بتنوم البيشنت completely، ف this is going to have some effect on the respiratory system, on their cardiovascular system, on their nervous system، ولكن local anesthesia is generally very low in complications، ما فيها لها مضاعفات يعني. And finally, the last advantage is that the patient can leave the clinic immediately after completion. يعني على طول أول ما يخلص العملية أو شو ما كانت بروح على السريع يعني. There's no need to stay overnight. So what are the criteria for local anesthetics؟ يعني لو اجينا نفكر بخصائص المخدر الموضعي المثالي شو ممكن تكون؟ هاي هي الكرايتيريا for the perfect local anesthetic أو the ideal local anesthetic. طبعا there is no ideal local anesthetic على أرض الواقع، ما في إشي اسمه مخدر موضعي مثالي، ولكن هاي الأشياء اللي إحنا بنستخدمها عشان نقارن بيناتهم. أول إشي في عنا rapid onset of action، يعني إنه بيشتغل أول ما نحطه. It has a very rapid onset of action. This is very important because if the local anesthetic takes a very long time to work، يعني مثلا بقعد ساعة ساعتين تيبلش يعمل effect، أنا ما استفدت إشي. خصوصا مثلا لما يجيني البيشنت already عنده ألم من إشي صاير مثلا they were stabbed for example، انطعن أو إشي زي هيك، وأنا بدي أشيل السكينة مثلا. This kind of thing they're already under so much pain، فأنا هسه إذا بدي اللوكال أنستاتيك يشتغل بعد ساعة ساعتين ما راح أستفيد شيء. For that reason we needed to have a very rapid onset of action. Secondly, adequate duration of anesthesia. So this means I want the duration of action to be long enough so that I will finish the procedure before the duration of action is over. يعني for example إذا كانت العملية طولها ساعتين، أنا بدي مفعول المخدر يكون 3 ساعات أو أقل، يعني ساعتين شوي. أهم إشي إنه يكون كافي، يعني مش مثلا تكون العملية ساعتين ومفعول المخدر ساعة، أنا هيك ما استفدت إشي. تمام؟ there has to be an adequate duration of anesthesia. مدة المفعول لازم تكون كافية. ثالث إشي I need to have a high intrinsic activity، meaning إنه مفعول الدواء نفسه لازم يكون عالي. ليش هذا الإشي بيهمني؟ لأنه كل ما زاد مفعول الدواء كل ما قلت الجرعة اللي لازم أعطيها للبيشنت، وهذا الإشي مفيد لأنه the lower the dose that I can give to the patient the lower the chance of complications. So this is good. رابع إشي low systemic toxicity، يعني in general the drug doesn't have many systemic effects. It doesn't have effects on the central nervous system or the cardiovascular system أو on the liver for example، لأنه بالنهاية these local anesthetics they will eventually be absorbed into the circulation وراح يوصلوا على كل أعضاء الجسم، فعشان هيك أنا ما بدي إياهم يكونوا toxic. But this is important. Then we have high efficacy toxicity ratio، يعني أنا بدي الافيكاسي أو الفعالية تكون أعلى كثير من الخطر أو التوكسيسيتي تبع الدواء أو السمية خلينا نحكي. But this is important because I want the drug to be as efficacious as possible and to have as low of a toxicity as much as possible. Then we have a low overall incidence of serious adverse effects. هسا في شوية adverse effects، كل دواء طبعا فيه side effects، ولكن بعض الأدوية بيكون فيها very severe side effects. For example الانافيلاكسس أو الhypersensitivity. such a serious adverse effect إذا كان موجود بالدواء راح يقلل من استعماله، لأنه إحنا بنخاف إنه يصير هذا الإشي بالبيشنت، فإحنا بنحبذ إنه اللوكال أنستاتكس يكون عندها low incidence of serious adverse effects، يعني حتى لو كان في احتمالية إنه تصير هاي الأشياء على الأقل تكون الاحتمالية قليلة جدا، تمام؟ عشان بشكل عام يكون استخدامها آمن. وآخر إشي the ideal local anesthetic does not have local irritation، يعني لما نيجي نحطه عند البيشنت، لما نيجي نخدر المنطقة ما راح تعمل irritation للمنطقة، ما راح تأذي المنطقة اللي بنحطها إحنا فيها. تمام؟ So what are the delivery techniques of local anesthetics؟ طبعا I said delivery techniques and not routes of administration، لأنه في إشي بدنا نركز عليه هون، إنه local anesthetics على عكس باقي الأدوية إحنا ما بدنا إياها توصل للدم عشان تشتغل. إحنا معظم الأدوية الثانية any other drug in order for it to be useful. أول إشي لازم توصل على جهاز الدوران. It has to reach the systemic circulation. وبعدين it has to circulate in the bloodstream until it reaches the target organ. شو ما كان الدواء، سواء كان دواء للكبد أو دواء للقلب أو دواء للجهاز العصبي، إحنا بدنا يا يدخل على الدم بعدين يكون it has to circulate in the blood and then reach the target organ. لكن التوبيكال اللوكال انستاتكس انا ما بدي اياهم يدخلوا على الدم، هم راح يدخلوا على الدم بالاخير ولكن they don't have to go to the blood in order for them to work. انا بس بدي اياهم يكونوا فعالين بالمنطقه اللي انا بحطهم فيها. فعشان هيك كلمه route of administration ما بنستخدمها هون، بل بنستخدم delivery technique. تمام؟ بس I wanted to make that clear. So the first delivery technique of local anesthetics is the topical route. ومن اسمها topical بتكون سطحية very surface level. تمام. This includes things like sprays, for example this pressurized spray can, or gels, for example this one right over here, ointments اللي هي المراهم, etc etc. أي إشي بقدر أحطه على السطح. تمام. It's not going to penetrate. This topical route has a very low duration of action. يعني مفعوله بيكون جدا قصير، بس ثواني أو دقائق بس. It's very very short in terms of duration of action. طبعا you might be asking, wait, if it has a low duration of action, seconds to minutes, when is it useful? هسه رح نشوف إنه there are some procedures that are very quick، جدا جدا سريعة. this will be useful in this case. The way that they work is by blocking the free nerve endings of the mucosal surface. يعني بيشتغلوا على نهايات الأعصاب, the very terminal nerve endings اللي بيكونوا موجودين على سطح الميوكوزا. تمام. In order to administer anesthesia to the surface only. زي ما حكينا, these are surface level anesthetics. We use them in very simple procedures requiring superficial anesthesia زي ما حكينا. شو هي البروسيجرز هاي؟ بيقول لك مثلا needle injections. For example, at the dentist, some patients don't feel very comfortable with needles. They are scared of needles or they feel pain from needles. We can use these sprays or gels, for example, to apply to the gums before we actually put the needle in order to administer anesthesia to prevent the patient from feeling pain. This is one example. Another example is orthodontic band placement. So orthodontic bands are part of the orthodontic braces اللي هي التقويم. التقويم بيكون جزء منه هاي الأورثودونتيك باند، عبارة عن شريط حديدي بلف حول السن زي ما انتم شايفين. And inserting this band is kind of painful, so we use a local anesthetic to relieve pain for the patient. It's very quick, it's inserted in like a minute, but that's why local anesthetic would be useful here. And gingival curettage, which the doctor didn't really go into details, so just اللي هي عبارة عن تنظيف اللثة، بيكون زي الحث outer layer of mucosa, but don't focus on it too much. So here we have what the topical anesthesia looks like. We have the spray blocking the free nerve endings at the mucosal surface, and here we have the cotton swab applying a gel at the gums of a patient. Okay, so the second delivery technique is infiltration. وهاي من اسمها بيكون فيها دخول. There is an actual insertion of a needle into the part of the body that we're trying to anesthetize. And so here you can see the local anesthetic is injected into the submucosa or supraperiosteally. So you can already see, it's actually a deeper anesthesia than the topical route. Topical route was very superficial, very surface level. لا, بالinfiltration it's a little bit deeper. We're working on a larger area. It's more deeper anesthesia. So let's talk about it. Submucosa means beneath the mucosa. Supraperiosteally means above the bone surface. فاحنا عم نحكي ما بين البون سيرفيس وما بين الاوتر layer of the mucosa. كل هاي المنطقة راح يكون فيها تخدير. تمام. This is where we will have the anesthesia. Now, there is no invasion of the main nerve trunk. يعني هسه رح تشوفوا بعدين انه في عندنا شويه تكنيكس بتكون لها دخل بالعصب الرئيسي او المين نيرف ترانك. بالانفلتريشن ما بيكون عندنا دخول او تخدير للعصب الرئيسي اللي هو the main nerve trunk. We are only anesthetizing a specific area that is innervated by terminal or peripheral nerves, not innervated by the main nerve trunk, as we will see later. The local local anesthesia of the peripheral terminal innervation only. يعني احنا عم نخدر المنطقة اللي بتكون تغذيتها من الأعصاب النهائية, the terminal or the peripheral nerves. We are not anesthetizing or blocking the main nerve trunk. تمام? This is the main distinction you have to understand here. Here, the local anesthetic is distributed in the soft tissue and adjacent bones which are innervated terminally زي ما حكينا. المنطقة بتكون مغذية من الأعصاب النهائية and becomes active at the terminal nerve ends زي ما حكينا. So it spreads in the soft tissue which is beneath the mucosa to anesthetize the region in which it is applied to, which زي ما حكينا is innervated by the terminal nerves, the peripheral nerves. We are not actually blocking the main nerve trunk. There's many examples of it زي ما راح نشوف. For example, here it's used on the gums of a patient or here on the foot of a patient, and the onset of action is pretty quick. يعني it takes a very short time to begin working. It takes a few seconds to 3 minutes and it will start numbing the area. تمام? So the third delivery technique is called a peripheral nerve block. ومن اسمها nerve block means that we're actually blocking or anesthetizing a total main nerve trunk. احنا بنركز هسه على عصب رئيسي وبنعمل له تخدير. So here the local anesthetic is deposited within close proximity to a main nerve trunk, ensuring anesthesia within the area supplied by the nerve distal to the injection site. تمام؟ So in essence we are dropping, احنا عم نعمل تنقيط أو تقطير للlocal anesthetic around the main nerve trunk. For example, this right here is the nerve we are working on, right? We are going to apply the needle or insert it right at this point just before we reach the nerve. احنا ما بدنا الإبرة إنها توصل للعصب، لا أبدا، لأنه إذا الإبرة وصلت للعصب it will cause damage. We want the needle to reach just above the nerve ومنبلش dropping the local anesthetic on the nerve. We are actually depositing the local anesthetic around the main nerve trunk. When we are doing so, everything distal to the point of injection is going to be anesthetized. يعني كل هاي المنطقة بعد منطقة التخدير راح تكون كلها مخدرة. تمام؟ But as we can see here, ensuring anesthesia within the area supplied by the nerve distal to the injection site. فيعني proximally this is not going to be affected. ولكن distally, distal to the injection site, all the areas supplied by the nerve are going to be completely anesthetized. And this is why peripheral nerve blocks are useful, because they have a larger action instead of only acting on a localized area. Here the onset of action is a little bit longer. It's gonna take some time to work, between 3 to 5 minutes. Examples of peripheral nerve blocks include the ID nerve block. هسا ال ID nerve اللي هو ال inferior dental nerve أو also called the inferior alveolar nerve، وهو بيكون عصب بالoral cavity that supplies the mandible, and it's very common in dentistry to use ID nerve blocks in many operations لأنه بيكون التخدير بيكون بيشمل منطقة كبيرة, which is very useful for the dentist. There's also the ulnar nerve block, which is in the arm, the median nerve block, the radial nerve block, all of which are in the arm, as we will see later. Again, I just want to stress on the point that we are not inserting the needle into the nerve. الإبرة ما بتلمس العصب. If it does, it will actually damage the nerve. We don't want that to happen. احنا بس بدنا نقطر local anesthetic. We want to drop it on the nerve, specifically at the point right here where we want to deliver the anesthesia. So here, for example, we have the inferior dental nerve or the inferior alveolar nerve block, which is very common in dentistry. As you can see, the dentist will basically insert the needle into the mucosa right over here, and just before they reach the nerve, they start dropping the local anesthetic. And as you can see, everything distal to the point of injection is going to be anesthetized, and it's very useful. Here we have the examples of the ulnar nerve block, the median nerve block, the radial nerve block. You can see that beforehand we are going to mark the areas where we're going to actually administer. So for example, this green line is actually the ulnar nerve, this green line is supposed to be the median nerve, and this over here is supposed to be the radial nerve, which is not visible here, I think. Yeah, the doctor didn't focus on this too much. Just know that, yeah, this is how we administer the peripheral nerve blocks. So the fourth delivery technique is known as a neuraxial block. ومن اسمها neuraxial means we are talking about the central nervous system, specifically the spinal cord. فهسه رح نيجي نحكي عن تخدير الحبل الشوكي. How is that going to work? There are two main techniques of neuraxial block. One of them is called epidural block, and the final one is called spinal block. So epidural block, min ismo, we are administering the local anesthetic in the epidural space, which is between the dura mater and the vertebral canal. This is called the epidural space. As you can see, we are inserting a catheter which goes in the epidural space. زي ما انتم شايفين هون معلمة epidural space هاي المنطقة هون, and we are depositing the local anesthetic in that area. And this is of course يعني حتى local anesthetic ما بيلمس الحبل الشوكي بالمرة. It doesn't come into contact with the spinal cord at all. There is no penetration of the meninges, there is no loss of motor function, there is only a certain level of anesthesia that is achieved with this kind of epidural block. تمام؟ ولكن the spinal block, on the other hand, here is where we have the actual penetration of the needle. It actually penetrates the dura mater. على عكس epidural, which doesn't penetrate the meninges, لا, spinal block actually penetrates the dura mater, and it also penetrates the arachnoid mater, and it deposits the local anesthetic in the subarachnoid space. It deposits the local anesthetic in the subarachnoid space. يعني it puts it very next to the spinal cord. تمام? This obviously has a longer duration of action. We're talking about a more effective kind of anesthesia, and because it's so close to the spinal cord, it may actually cause a loss of motor function. ممكن يتأثر على حركة المريض. ولكن epidural block لا, it only causes a loss of sensation. Okay? So I think we are done now with the delivery techniques. This is just a recap of the spinal anesthesia. Like we said, it's the injection of local anesthetic around the spinal cord. It's divided into two types. The epidural anesthesia is what we call depositing local anesthetic in the extradular space, or epidural space. The needle enters the spinal canal but does not penetrate the meninges. تمام? So there is no penetration of the meninges. هي بس on top of the dura mater and beneath the vertebral canal. بينما true spinal anesthesia, أو اللي احنا سميناها spinal block, here we have a subarachnoid axis. We are actually depositing the local anesthetic into the subarachnoid space, usually known as spinal anesthesia, in which the needle penetrates the dura mater. Okay? So let's talk about some logistics of local anesthetics. First of all, in the clinic, in the hospital, you're going to see local anesthetics stored in these very small vials. تمام؟ بيكون تقريبا قد الأصبع. Each one of these is called a cartridge or a carpool. تمام؟ These are the vials containing the local anesthetic solution, and they are called cartridges or carpules. وهاي هون عبارة عن علبة كاملة بتحتوي على أبصر كم من هذول, a very large number of these carpools. تمام؟ It's important to know here that each one of these carpools contains 1.8 milliliters of solution. I know this sounds very specific, but you have to know it, لأنه بعدين رح نيجي نعمل حسابات رح تعتمد على هذا الرقم. So make sure you remember it. Now the importance here زي ما حكينا is to find out how many carpools we can give to a patient. لازم تعرف إنه الكاربولة الوحدة فيها 1.8 milliliters, لأنه بعدين رح نيجي نعمل حسابات إنه كم كاربولة بقدر أعطيها للبيشنت. It's important to understand this. Just keep it in mind. So let's talk about the contents of cartridges. Local anesthetics come in different formulations على حسب الشركة اللي بتعملها. فالشركات اللي بتصنع اللوكال anesthetics إما بتعملوا plain anesthesia, يعني مخدر حاف بدون أي شيء ثاني, أو بتعملوا anesthesia with vasoconstrictor, يعني it basically includes the local anesthetic with a vasoconstricting agent. وبعدين رح نحكي ليش ال vasoconstricting agent مهم وشو استعمالاته, بس now we're going to take an overview. Plain anesthesia consists only of the local anesthetic agent اللي هو الدواء المخدر زائد الvehicle. الvehicle اللي هو عبارة عن المحلول, the actual solution that dissolves the local anesthetic. This is usually normal saline, which is 0.9% sodium chloride. This will make the drug it will make the drug isotonic, so that when we inject it into the patient, it doesn't cause hyperosmolarity or hypoosmolarity. It will keep everything isotonic. On the other hand, anesthesia with a vasoconstrictor, it not only contains the local anesthetic agent and the vehicle, ولكن on top of that, it also contains a vasoconstrictor agent. تمام? And we'll see later why this is important. وغير هيك كمان انه مع الفازوكونستريكتور ايجنت usually comes a preservative، يعني ماده حافظه لهاي الفازوكونستريكتور، لانه the vasoconstrictor usually undergoes degradation يعني بتأكسد، ف we usually add a preservative so we extend the shelf life of this anesthetic عشان ما يخرب على السريع. This is usually something like sodium bisulfite, for example, or any other preservative. So let's talk about the chemistry of local anesthetics. You have to understand that most local anesthetics have this general chemical structure. Okay, let's examine. First of all, they have a lipophilic group, يعني a lipid soluble group. This lipid soluble group is typically aromatic. شو يعني aromatic؟ يعني بيكون فيها a benzene ring. شايفين هذا benzene ring؟ This is another benzene ring. But these are called aromatic groups, and because these aromatic groups are basically just carbon and hydrogen, they are very lipophilic. They are soluble in lipids. تمام؟ Then we have what we call the intermediate bond. The intermediate bond is basically just a specific group in the middle that connects the lipophilic group to the hydrophilic group. تمام? This intermediate bond has two types. It could be an amide bond, such as this one over here, C double bond O NH, or it could be an ester bond, such as this one over here, C double bond O O. And then finally we have the hydrophilic group, which is attracted to water or soluble in water. This will give water solubility to the local anesthetic, which is a useful thing, definitely. We want it to be soluble in water so that we can easily administer it to the patient. Here we have the tertiary amines actually forming the hydrophilic head of the local anesthetic. And that's it. So let's start discussing the difference between the ester type local anesthetics and the amide type local anesthetics. زي ما شفنا قبل شوي, the intermediate bond can either be an ester bond or an amide bond. This distinction is what is going to form the two major groups of local anesthetics, الester types والamide types. So, ester type local anesthetics, زي ما شفنا, they contain an ester intermediate bond, just as this one right over here, C double bond O O, which is an ester group. Okay, let's start talking about them in more detail. The ester type local anesthetics are metabolized in the plasma by a pseudocholinesterase enzyme. تمام? This enzyme, pseudocholinesterase, is found in the plasma. It metabolizes these local anesthetics into para-aminobenzoic acid, also called PABA. تمام? This is the shorthand acronym. Para-aminobenzoic acid is responsible for allergic reactions in many people. في كثير patients عندهم حساسية من para-aminobenzoic acid، فلما نيجي نعطيهم ester type local anesthetic, they are going to have a severe hypersensitivity reaction to the drug because of this para-aminobenzoic acid. تمام? It's responsible for allergic reactions. Examples of ester type local anesthetics include things like procaine or tetracaine or benzocaine or even cocaine. Even though we know cocaine as being a indirect sympathetic agonist, ولكن it also acts as a local anesthetic. This is again an interesting information to know. Procaine is rarely used in dental medicine. It was very heavily used back in the day. كان اسمها Novocaine، كانت تستخدم بكثرة في عيادات الأسنان. ولكن again, because of the production of para-aminobenzoic acid and because of the hypersensitivity risk, it has been completely discontinued and it is no longer used. Tetracaine is used sometimes in topical anesthesia or in spinal anesthesia. هسه كمان شوي راح نشوف انه الester type local anesthetics they are almost completely discontinued from medical use. احنا ما بنستخدمهم لانه زي ما حكينا the production of para-aminobenzoic acid is very dangerous. A lot of patients have severe hypersensitivity reactions. To be on the safe side بطلنا نستخدم هاي الادويه. زي ما حكينا they have more adverse effects, mainly the hypersensitivity reaction than the amides, so they are rarely used nowadays. They are excreted in the kidneys of course or in the urine. يعني باختصار the patient will urinate these drugs out. فاللي راح يصير انه metabolism is going to take place in the plasma by the pseudocholinesterase enzyme وبعدين this will be filtered in the kidneys and it will be excreted in the urine. Here we have the reaction I was telling you about, the metabolism of ester type local anesthetics in the plasma. This is an example. This is procaine. In the plasma, it will be hydrolyzed by the enzyme pseudocholinesterase into this metabolite, which is relatively harmless, and this dangerous metabolite, which is para-aminobenzoic acid, and this is what's going to cause a hypersensitivity reaction. Here we have the example of a lady who has been administered with a local anesthetic from the ester type, and this is the progression of the hypersensitivity reaction. We can see in the first picture she looks relatively normal, then we can see some swelling in the cheek and lip area, and then we can see it becoming more and more severe until it becomes extremely swollen, such as in this picture over here. But this can be very dangerous, especially if the swelling takes place in the larynx, and this will eventually block the airway. And this is, that's why we no longer use them. The amide type local anesthetics, just like we said, they have replaced the ester type local anesthetics because the ester type is largely a cause of hypersensitivity. فصرنا نستخدم احنا هاي الأيام الامide type. They are the most commonly used local anesthetics. They are metabolized mainly in the liver by the cytochrome P450 system or the microsomal enzyme system. There are some exceptions to this general rule. For example, the drug Articaine is metabolized in the liver and the plasma, and the drug Prilocaine is metabolized in the liver and the kidney. فيعني ولكن بشكل عام most of the amide type local anesthetics are metabolized in the liver. Okay? هسا Prilocaine, there's another big piece of information that the doctor gave us, is that it can cause methymoglobinemia. We're going to discuss this in more detail later. Just keep this in the back of your head. The excretion, of course, is in the kidneys, in the urine, of course, زي ما حكينا, just as this picture shows over here. Most of them are metabolized in the liver where they are inactivated, and then they are excreted in the urine. The first amide type local anesthetic is lidocaine. It's very potent, very effective, very safe. وراح نشوف بعدين انه it's very heavily used in medicine. It's the drug of choice for local anesthesia. It has زي ما حكينا the amide type local anesthetics, they have a higher efficacy and better tolerance than the ester type local anesthetics. فعشان هيك we no longer use the ester type لأنه these amide types they have a higher efficacy, but they are more potent and they have a better tolerance, meaning that the patients do not develop as many adverse reactions to these medications. Examples include lidocaine, bupivacaine, ropivacaine, mepivacaine, prilocaine, articaine, etc. Here we can see an example which is lidocaine, and we can clearly see the amide intermediate bond right over here, C double bond O N H. So we talked about prilocaine causing methymoglobinemia. What is methymoglobinemia? Methemoglobin is basically a form of hemoglobin in which one of the heme groups has the ferrous oxidized into ferric أو Fe2 plus oxidized into Fe3 plus. زي ما احنا عارفين each hemoglobin molecule has 4 subunits زي ما انتم شايفين. Each one of these subunits has one heme group. This heme group has an Fe2 plus iron atom in the center اللي هي مسميها الفرس. تمام؟ This ferrous is the normal state and it's called hemoglobin and it carries oxygen. ولكن when one of these heme groups becomes oxidized into ferric, that's when it is called methemoglobin. Now, what is important about this methemoglobin? The importance is that this heme group, which is oxidized into ferric, has a reduced ability to bind oxygen, meaning that it does not bind oxygen. This causes the remaining functional heme groups to increase their binding to oxygen. So they bind to oxygen much more tightly. When they do so, this increases the oxygen affinity of hemoglobin. لأنه زي ما انتم شايفين هاي الهيم groups عم بتمسكوا بالأكسجين بكثرة وبشدة. They are very heavily binding oxygen, more tightly. But this means when the hemoglobin reaches the tissues, it will not be able to deliver the oxygen لأنه the oxygen affinity is very high. This will prevent oxygen delivery and it will cause hypoxia and possible necrosis. Why does this happen? Why does prilocaine cause methemoglobinemia? بيقول لك لأنه the metabolism of prilocaine produces aminophenol metabolites, and these aminophenol metabolites they oxidize the ferrous into the ferric. Okay? So الهايبرسنسيتيفيتي كوشنز already حكينا عنهم. الاستر تايب لوكال انستيتكس قلنا انه كلهم بطلنا نستخدمهم لانه all of them are metabolized into para-aminobenzoic acid. فعشان هيك if a patient is allergic to one of them they are allergic to all of them لأنه كلهم they have the same metabolism, they all produce the same hypersensitivity invoking chemical واللي هو البارا امينو بنزويك acid. فعشان هيك احنا إذا البيشنت كان حساس لواحد منهم فهو حساس لهم كلهم. بينما الامide type local anesthetics they have a lower risk of hypersensitivity and they all have their own unique metabolism يعني they don't have a common metabolite. This means إنه if a patient is allergic to one of the amide type local anesthetics it is safe to substitute for another amide type local anesthetic. Substituting within this class is safe and they don't have a shared common hypersensitivity causing chemical. So what is the mechanism of action of the local anesthetics? Just like we said in the beginning, we want to inhibit sensory impulses from reaching the brain, so we inhibit action potentials from taking place. This involves inhibiting this depolarization step. And how does that happen? We inhibit depolarization by inhibiting the entry of sodium ions into the neuron. How do we do that? By inhibiting the action of the voltage-gated sodium channels, as we will see later. So here we have the mechanism of action. This right here is an integral membrane protein, which is the sodium channel, the voltage-gated sodium channel. You can see, this is the outside of the neuron. This is the inside of the neuron. The way this channel works is that when it opens, it allows sodium to enter the neuron so that there will be a depolarization so that the membrane potential is going to decrease or يعني become less negative, and this is going to cause the cell to undergo action potential, which will lead to a sensory impulse that travels to the brain and causes whatever sensation. We want to prevent this from happening. فعشان هيك we have the drug here, which is the local anesthetic. The local anesthetic is going to bind right over here. زي ما انتم شايفين, it's going to bind at the intracellular site of the voltage-gated sodium channel, and it's going to block the entry of sodium. تمنع الصوديوم من انه يدخل على النيورون, which will therefore prevent depolarization from happening. It will prevent action potentials from happening, which will therefore prevent pain from taking place. تمام? Now, let's look at this picture in more detail. As you can see, the drug, when it is administered into the patient, it is in the cationic form. You can see there's a plus sign here indicating that it is positive. Now, this drug is going to become deprotonated, and it's going to lose a proton, زي ما انتم شايفين, it's going to lose a proton, and it's going to form the uncharged drug. The uncharged drug, يعني غير مشحونة. This uncharged drug is able to penetrate the lipid membrane because it is lipophilic, it is lipid soluble. But as you can see, it will diffuse across the membrane and it will reach the intracellular cytoplasm. Once it reaches the cytoplasm, now this uncharged drug has to go back into its cationic form. ليش؟ لأنه only the cationic form can actually bind at the receptor site. فعشان هيك it has to gain a proton, it has to become the positive cationic form, and then it can actually become effective. But this is basically the cycle of events. You can see in أول إشي it loses a proton to become the uncharged base, which diffuses across the membrane, enters the cell, then it gains a proton to become the cationic form, which then binds at the receptor and causes anesthesia. So let's talk about some pharmacodynamics. Just like we said, the uncharged drug, which is actually a weak base, as we will see later in more detail, this uncharged drug is lipid soluble, so it will cross the membrane. ولكن the protonated or the charged drug or the cationic drug is the active form of the drug, and this one will actually interact with the receptor. فزي ما شفنا reversible binding with the alpha subunit of the voltage gated sodium channel. The cationic form is going to reversibly bind with the alpha subunit of this sodium channel, which will block any sodium entry into the neuron, which will reduce depolarization amplitude and the transmission of action potentials. فراح تمنع الاكشن potential من انه يحدث، وراح تمنع النقل العصبي او الاكشن potential انه actually it moves to the central nervous system. It will prevent the transmission. With increasing doses, creation of action potential can be completely prevented. If we actually increase the dose beyond a certain limit, creation of action potential will be completely prevented. We have to be careful with the doses that we give the patient. Okay, so now we're going to talk about the physicochemical properties of local anesthetics. We're going to delve into some chemistry now. We're going to recall some chemistry we took in the very first semester of our medical school journey, and yeah, that's going to be fun. So the onset of action of local anesthetics depends on a couple of factors, 5 as you can see here. Now we're going to focus on the first two, which is the tissue pH and the local anesthetic pKa. Now, I want you to remember that the pKa is a measure of the acidity or the basicity of a chemical. يعني هو عبارة عن مقياس أو معيار لحامضية أو قاعدية أي مادة كيميائية. How is this scale working? Well, let's just say that pKa is a scale that runs from 0 all the way to 14. تمام? So a pKa that is from 0 to 3 is something that is strongly acidic. And a pKa that is between 4 and 6 is something that is weakly acidic. And a pKa that is around 7 is mainly a neutral chemical. A pKa that is between 8 and 10 is a weak base or weakly alkaline. Alkaline means the same thing as base. And a pKa between 11 and 14 is something that is a little bit more strong, a stronger base. Tamam? Just keep this in mind because this is going to be very important later on. Tamam? Since we're on the topic of weak and strong bases, I want you to remember the distinction between these two. Now, a strong base, like sodium hydroxide, for example, what makes it unique is that it dissolves completely with complete dissociation when it interacts with water, so that there is complete ionization, as you can see, into the actual base. So there is no reversible reaction. All of the sodium hydroxide becomes ionized in water. Tamam? Whereas a weak base, such as this one over here, it's an arbitrary base, we're going to call it B. You can see that it's a weak base because when it interacts with water, it's a reversible reaction. It goes both ways, forward and backward, which means that not all of the base is going to dissociate or ionize in water, which means that at any point in time, there's going to be some part of the base that is ionized and some part of the base that is unionized. This is the ionized form and this is the unionized form. This is a weak base, just like we said. But when you compare it to something like sodium hydroxide, all of the sodium hydroxide is going to be ionized in water. Tamam? You will find 0 of the unionized form. Okay? Now, there's other factors that influence the onset of action. These include things like the local anesthetic concentration, lipid solubility, nerve morphology. We're going to look at these two later on. This nerve morphology, we're not going to touch on it in this lecture. Okay? So let's continue. Let's do some chemistry revision. So when the pKa of a chemical is greater than the pH of the medium that it is in, يعني when you place a chemical that has a higher pKa than the pH of the medium in which it is in, the chemical acts as a base and accepts protons. Now that makes sense. For example, if you have a medium with a pH of 4, for example, and you drop a chemical with a pKa of 8. So a pKa of 8 is a basic chemical, and you drop it in an acidic solution of a pH of 4. This means that the chemical is going to act as a base, and it's going to accept protons, just as in this equation right over here. The base is going to accept protons, and it's going to become ionized. Okay? The higher the difference, the more protons it accepts, and the higher the amount of the ionized form. يعني, if the difference between the pKa of the chemical and the pH of the medium is very high, for example, if the pH was 2 and the pKa was 10, this means that the medium is very, very acidic and the chemical is very, very basic, which means the reaction between them is going to be strong, so there will be a high acceptance of protons, which means that the higher the amount of ionized form of the base, most of the base is going to exist in the ionized form. تمام? On the other hand, if the difference is very small, for example, if the pH is 6 and the pKa is 8, this means that the medium is only very slightly acidic and the chemical is only very slightly basic. So the reaction between them is not going to be as strong, which means that it's not going to accept as many protons. So most of the chemical is going to be in the unionized form. I hope you understand that, because this is very important when we talk about local anesthetics later, and you'll see why. Again, when the pKa of a chemical, this is the opposite situation. Now, when the pKa of a chemical is less than the pH of the medium, tamam, this means that the chemical here acts as an acid and donates protons. For example, when the pKa of the chemical is 4 and the pH is 8, in this case, you are dropping an acidic chemical into a basic medium. So the chemical is going to act as an acid and donate protons to the basic medium. As you can see in this reaction over here, this is, for example, the acid that we're talking about, the ammonium ion. When you drop it into a basic solution, for example, of pH 8, it's going to donate protons and it's going to form this right over here. Hello? But this is important. Again, the same situation here. The higher the difference between the pKa and the pH, the more protons it donates, so the higher the amount of the unionized form. You can see it's the opposite situation here for acids. This is for acids because acids donate protons, which means that when they actually react, they don't become ionized, they become unionized, as we can see in this situation over here. So when the higher the difference between them, the greater the reaction or the stronger the reaction, which means that the acid is going to donate more protons, so there's going to be a higher amount of the unionized form. For the purpose of this lecture, I want you to focus on this more because this will be very important later on. So, continuing with the physicochemical properties of local anesthetics, you have to understand that most local anesthetics are weak bases, and this is why I told you to focus on the first part, because the majority of this lecture will focus on this point right over here, is that most local anesthetics are weak bases, which means, like we said, that their pKa is going to be somewhere between 8 to 10. This is the majority of local anesthetics. So a weak base, when you drop it in a solution, for example, of a neutral pH, a pH of 7, it's going to be part ionized and part unionized. صح ولا لا? It's not going to dissociate completely. Part of it is going to be dissociated and it's going to be ionized, and the other part is going to be unionized. But this is very important. For the local anesthetic to be absorbed, it should be in the unionized form, and the unionized form should be lipid soluble. This is very important because if you're administering a local anesthetic into a tissue medium that contains neurons, you want this local anesthetic to enter the neurons. صح ولا لا? Look at this figure over here. This is the lipid membrane of the neuron. This is the tissue medium on the outside, and this is the cytoplasm of the neuron. Tamam? If you want the local anesthetic to work, you have to make the local anesthetic cross the membrane. You have to make it diffuse across the membrane so that it can interact with the voltage-gated sodium channels on the inside surface, right? And so in order for this to happen, the local anesthetic has to be in the unionized form. Remember, it's a weak base, which means that there has to be some unionized form of this weak base that is able to diffuse across the membrane and then interact with the receptor, okay? And of course, this unionized form itself has to be lipid soluble, which we know it is because they have a lipophilic part, if you remember from the chemistry. So yeah, the absorption depends on the proportion of the unionized molecules when the local anesthetic enters the tissue medium. شو معنى هذا الحكي? Since we're talking about weak bases, this means that when you drop this local anesthetic into the tissue medium, there's going to be a specific proportion of the ionized form and a specific proportion of the unionized form. Tamam? Now, when the proportion of the unionized form is high and the proportion of the ionized form is low, this means that most of the base is in the unionized form, which means that most of it can diffuse across the membrane, which means that the onset of action is going to be very fast. Tamam? بينما, if the proportion of the ionized form was very high and the proportion of the unionized form was very low, this means that most of it cannot penetrate the membrane, so the onset of action is going to be very slow. Okay, this is why it's important here. Alright, So once again, visiting the pKa, which is the dissociation constant like we said, the pKa is a drug-specific constant, which means that later on you will see that each of the local anesthetics will have their own value of the pKa. It's a drug-specific constant indicating the pH value with equal shares of uncharged base and cation. شو معنى هذا الحكي؟ So the pKa زي ما حكينا, it is the pH value with equal shares of uncharged base and cation. So when you drop the local anesthetic into a pH that is equal to its own pKa, let me say this again, when you drop a local anesthetic into a tissue medium that has the same pH as its pKa, there's going to be equal proportions of the ionized and the unionized form, أو اللي هو the uncharged base and the cation. Okay, so for example, if the pKa is 8 and you drop it into a medium that has a pH of 8, there's going to be 50% ionized form and 50% unionized form. Okay. Now, like we said, local anesthetics, since they're weak bases, they have a pKa value between 7.7 and 9.0. So they are weak bases. Once injected, the solution has to be buffered in the tissue first. What does this mean? Because the tissue is relatively more acidic, it's 7.4, أو خلينا نحكي less basic. تمام. This means that when you drop a local anesthetic, which is, it's a stronger base than the medium, there's going to be some buffering action, meaning that there's going to be a reaction between the weak base, which is the local anesthetic, and the, let's just say, more acidic medium, which is the tissue. تمام. This buffering will include a donation of protons from the tissue medium to the weak base. Remember what we said, when the pKa is higher than the tissue medium pH, there's going to be a donation of protons from the tissue to the weak base itself. But this is what we call the buffering, and which means that there's going to be a specific proportion of the ionized and the unionized form, as we will see later. So after buffering, the local anesthetic agent will have ionized and non-ionized forms. بالنهاية, after the reaction takes place and after the tissue medium donates protons to the base, we will end up with a certain proportion of the ionized and the unionized forms. Now, only the non-ionized forms will penetrate the cell. Remember this, we've said it before, and it's important. So, we're going to revisit an old equation, which is the Henderson-Hasselbach equation. This equation, as you can see, is the pH equals the pKa plus the logarithm of the uncharged base over the cation. Okay, pH equals pKa plus the log of the uncharged base over the cation. Now, when does this equation become useful? It becomes useful when we want to calculate the proportion of the unionized form that is in a specific local anesthetic when we drop it into a solution. ليش؟ لأنه I want to know whether this local anesthetic has a high onset of action, يعني very long onset of action, or a very short onset of action. How do I determine this? Well, if the local anesthetic, when it is dropped into a medium, has a high proportion of the unionized form, اللي هو will be our uncharged base, it's going to have a very short onset of action. بينما, if I drop a local anesthetic into a tissue medium and it has a very high proportion of the ionized form, or the cation, it's going to have a very long onset of action. So I use this equation to calculate the proportion of the uncharged base to the cation so that I will understand the extent in which it is going to be absorbed and therefore the onset of action. So let's take some examples of how this can happen. So let's say, for example, that the tissue medium has a pH of 12. Tamam? It's very basic. This would never happen, but just imagine. Okay, it has a pH of 12 and your local anesthetic has a pKa of 8. So this means in this case that the pH of the medium is larger than the pKa of your drug. What does this mean? This means that the medium is much more basic than the drug that you're administering, which means that when you drop the drug into the medium, it's not going to accept any protons. The medium is not going to donate any protons because it's already much more basic, which means that most of the drug is going to stay in the unionized form. Let's do this mathematically. So let's take this equation. The pH is equal to 12, so this is equal to 12 right here. The pKa is equal to 8, so this is equal to 8, plus logarithm of B over BH positive. So the equation, this equation right over here, comes up to 12 equals 8 plus the logarithm of B over BH positive. Now, if we send 8 to the other side, it becomes negative. 12 minus 8 is 4. So now we have the logarithm of B over BH positive equals 4. We do some math, and we eventually come up to this equation, which states that the B, which is the uncharged base, equals 10,000 times the BH positive, أو اللي هي the cationic form. What does this mean? This means that the uncharged base is 10,000 times greater in concentration than the ionized form, which means that this local anesthetic is going to have a very, very short onset of action. It will be absorbed fantastically because, as you can see, most of it is uncharged base. Okay, this is a good thing. So we have more unionized form, so it means we have more absorption. So we have a shorter onset of action. طبعا, obviously, I want you to remember, this would never happen. A pH of 12 is almost impossible in a tissue medium, but this is just a hypothetical situation. Let's take a more real example, okay? Let's say, for example, that the pH of the tissue medium was around 6, which is plausible, and the pKa was 8. What happens now? What about the actual absorption now? So in this case, the pH is less than the pKa. The pH is 6, the pKa is 8, which means that you're dropping the weak base, which is the pKa of 8, into a slightly acidic medium that has a pH of 6, which means that the medium is going to donate protons to the base, which means that there is going to be a certain proportion of the base that is going to be ionized. Let's calculate it. Let's do the equation. pH equals pKa plus the log of B over BH positive. The pH is going to be 6. The pKa is going to be 8 plus the logarithm. So we have the equation over here. We send 8 to the other side. It's going to go negative. 6 minus 8 is negative 2. So the logarithm of B over BH plus equals negative 2. We do some math here, and we end up with this equation, which means that the B equals 10 to the power of negative 2 BH plus, which means that the uncharged base is much less than the cationic form. Or in other words, the cationic form is much more than the uncharged base. So we have more ionized form. More ionized form means that we have less absorption, which means this local anesthetic is going to have a longer onset of action. Tamam? It's going to take a longer time. Alright, I hope this example really sets it into place, and I hope you understand this because it's very important. So the conclusions here is that a local anesthetic agent given in an acidic environment will have a delayed onset of action. زي ما شفنا قبل شوي. When you drop it something with a pKa of 8 into a pH of 6, we saw how most of the drug becomes ionized, which means that the absorption is going to be very low, so the onset of action is going to be delayed. It's going to take a longer time to finally come into effect. In an acidic tissue pH, does this actually happen? Do we actually have situations where the tissue pH is acidic? Yes, بيقول لك such as an abscess due to an inflammation, for example. In this case, the tissue pH will actually be acidic. So this is a real situation. The amount of the uncharged drug is reduced, while the amount of the cationic form is high, which reduces the effectiveness of the local anesthetic. Okay? So this is kind of a practical thing for you. Let's say, for example, a patient comes in with an abscess. You have to clean it out. So you apply a local anesthetic. And it's going to take some time to work because it's a very acidic medium. And of course, the higher the pKa value of a substance, in other words, the stronger of a base it is, the more basic it is, the lower is the portion of free base, which makes sense because if it's a stronger base, it's going to accept protons very strongly, meaning that most of it is going to be in the ionized form, which means that there's not going to be enough uncharged base to actually dissolve into the membrane, so the onset of action is going to be delayed. So the slower onset of action. I know I rambled a lot, but I hope that all of this has made the point very clear. So here we have an example of a comparison between different drugs and their different pKa's. Here we have lidocaine, methymoglobinemia, prilocaine, articaine, and bupivacaine. So We just said that the higher the pKa of a local anesthetic, the slower the onset of action, and we explained why. Is this true? Let's see. So let's take an example. Mepivacaine, which has a pKa of 7.7, the onset of action is between 2 to 4 minutes. When you compare it with something like bupivacaine, which has a pKa of 8.1, you can see that the onset of action is 4 to 8 minutes, which is longer than 2 to 4 minutes. So yeah, it does make sense. The higher the pKa, the more basic it is, the more strongly it accepts protons, the more the proportion of the ionized form, the less the absorption, and therefore the higher the onset of action, or the more delayed the onset of action. So, what are the other physicochemical properties that influence the onset of action other than the tissue pH and the pKa of the agent? We talked about lipid solubility. And here we're talking about the lipid solubility of the uncharged base. And this is important because the neuron membrane is 90% lipid. So you want something that is able to diffuse across this membrane. So lipid solubility affects the ability of local anesthetics to pass through neuronal membranes to reach their target receptors on the cytoplasmic side of the voltage-gated sodium channels. So here, for example, this is the outside, this is the inside. You want something that is able to diffuse across the membrane. So increasing lipid solubility will have a bunch of positive effects and some negative effects, right? So you might be thinking, okay, if we increase the lipid solubility, this will increase the diffusion of the drug. This will reduce the onset of action, make it more faster. So this will make the drug overall better, right? Well, yes, let's see. So increasing the lipid solubility of the drug will allow for better penetration to the nerve membrane, which is already 90% lipid. But yeah, it will shorten the onset of action. This will give us a rapid onset and a high intrinsic anesthetic activity. ليش? Which means this, why does it have a high intrinsic anesthetic activity? Because an increased lipid solubility means that you will only have to use a smaller amount of the drug to achieve the same anesthetic effect. لأنه this smaller amount will completely diffuse across the membrane and therefore will give you the same effect as something else with a lower lipid solubility. تمام? ولكن we have a potential drawback here, which I show in red, and it says higher systemic toxicity, especially because of its affinity to the central nervous system. If something is lipid soluble, it's more likely to dissolve into the blood-brain barrier and end up in the brain and spinal cord, so it's more likely to have some systemic toxicity. So this is a potential drawback to the lipid solubility of our local anesthetics, something to keep in mind. So let's talk about duration of action, something we haven't discussed. So the duration of action obviously depends on the local anesthetic binding to the axon membrane, meaning that the longer the local anesthetic binds to the axon membrane, the longer it's going to work. This binding depends on multiple factors. First of all, the agent itself. Some agents intrinsically bind for longer periods of time than others, so that's the difference. It depends also on the dose and concentration of local anesthetic. If you're giving the patient a high dose, then obviously there's going to be a larger amount of local anesthetic, which will stay bound to the axon membrane for a longer period of time. Same thing for the concentration. It's different from using 2% lidocaine is not the same as using 4% lidocaine. Tamam? For the concentration also matters. Whether or not a vasoconstrictor is included. Now, using a vasoconstrictor will affect the duration of action, and this is very important, and we're going to talk about it later in more detail. Just keep it in mind. And of course, the technique of application, whether you're using a topical anesthetic or infiltration or peripheral nerve block, etc., etc. Here we have the different drugs and the comparison in the duration of action. And you can see the difference in their actual intrinsic activity. So for example, Procaine intrinsically has a short duration of action when you compare it to something like Tetracaine, which has a long. Tamam? So let's talk about the use of vasoconstrictors and why they're important in influencing the duration of action. So vasoconstrictors, what do? They cause the constriction of the capillaries and all the blood vessels in the area that you're anesthetizing. Tamam? This vasoconstriction, what is it going to do? It's going to reduce the blood flow to that area. Why is that important? When you reduce the blood flow, you're decreasing the rate of absorption of the local anesthetic into the cardiovascular system, which means that the drug is going to stay for a longer period of time in the area that you want to anesthetize, which will increase the duration of action, right? This will achieve two major benefits. It will decrease the plasma levels of the local anesthetic, which means that there's going to be a lower risk of local anesthetic toxicity. And this makes sense. When you vasoconstrict the blood vessels in the area, you are reducing the blood flow, you are reducing the peak plasma concentration of this local anesthetic, and therefore leading to lower levels of toxicity or lower risk of toxicity. And another thing, you're also increasing the duration of action and increasing the depth of anesthesia, because most of the drug stays localized to the area and doesn't get washed away by the blood supply. Okay? There's also the benefit of decreased bleeding at the site of local anesthesia administration, which is useful because applying the needle can sometimes cause bleeding, so using a vasoconstrictor can really help. So, most local anesthetics have some degree of vasodilating activity, and this is important, right? Which means that they cause an increased uptake into the circulation. اللوكال anesthetic نفسه بيعمل vasodilation, some degree, مش كتير يعني. This vasodilation will increase the blood supply, it will increase the washing of the local anesthetic, and increase the uptake into the circulation, which means that the local anesthetic will reduce its own duration of action. فعشان هيك especially in highly perfused regions اللي بيكون فيها الدورة الدموية جدا جدا غنية, these local anesthetics will be washed away very quickly, but will have a short duration of the local anesthetic effect, which is insufficient for many procedures. Therefore, many local anesthetic preparations often contain a vasoconstrictor because it is very useful in reducing the blood supply, preventing the uptake of the local anesthetic, and increasing the duration of action. So by adding the vasoconstrictor epinephrine, and we know epinephrine is the endogenous adrenergic agonist, it's a very, very powerful vasoconstrictor. By adding it, the rate of local anesthetic absorption is decreased, meaning that less and less of the drug is getting absorbed into the circulation every minute. So this minimizes systemic toxicity and it increases duration of action, something we've already touched on. So it's very good, right? Well, there's one potential drawback, is that there's a risk of necrosis, especially when you're talking about an area that has a poor blood supply or a single blood supply. You have to be very careful. Local anesthetic agents with vasoconstrictors should not be administered to regions with a single blood supply like the toes. Why? Because if you're vasoconstricting that region, you're going to basically cut off the blood supply completely, and this is bad. You're going to cause ischemia and necrosis, which is, we're all familiar with what necrosis looks like. You definitely don't want that to happen. All right, so be careful when administering these agents into the regions with a poor blood supply or a single blood supply. So epinephrine, let's talk a little bit more about it. It's the most potent and efficient of the vasoconstricting drugs because it's endogenous, right? It's an endogenous chemical, so it's going to be very, very potent. Epinephrine as a salt is highly soluble in water, which is useful. We want it to be soluble in water because the formulation itself is 0.9% sodium chloride. And sodium bisulfite is added to delay the degradation of epinephrine, something we already discussed in the beginning. We said that we add a preservative to delay the degradation of the epinephrine. Here, for example, we have a full box of lidocaine cartridges, which contains epinephrine, as you can see, 1 to 100,000. This is the concentration of epinephrine. So what are some precautions to the use of local anesthetics? Let's talk about them. The first one are toxic reactions. So toxic reactions means that the drug itself gets absorbed into the systemic circulation and it basically causes different widespread systemic toxicity. This toxic reaction is caused by high plasma levels. يعني كميات الدواء تدخل على الدم بشكل كبير, which basically leads to the undesirable systemic effects. This increase in the plasma level of the local anesthetic is caused by multiple things. One of them is excessive dosage. If you give the patient a dose that is very high, this means that there's going to be a very high peak level of the drug in the plasma, which is going to cause toxicity. Secondly, we have rapid absorption. Rapid absorption can sometimes happen with certain local anesthetics if they are rapidly absorbed, especially in a very heavily vascularized region. This will lead to a high peak level in the plasma, which will therefore lead to the systemic toxicity. Here is where we can use vasoconstrictors. This is an advantage, and the vasoconstrictors will prevent this rapid absorption and therefore prevent systemic toxicity from happening. Number 3 is an unintentional IV injection, especially of bupivacaine, which is known to cause cardiotoxicity, usually during dental surgery. So you've already know what it is, unintentional IV injection. When we give local anesthetics, we definitely don't want to give it IV. We're only anesthetizing the local region. We never administer the drug directly into the circulation. So if, la samahallah, the needle goes into the vein, that's when it will start going around the body, and it's going to get in very high doses, and it's going to cause systemic toxicity. Now, this usually happens during dental surgery when we are giving the local anesthetic lingually. Now, the tongue, and especially the regions under the tongue, are very rich in vasculature, which means that if you're trying to anesthetize the area with a needle, you are very likely to hit a blood vessel, and therefore unintentional IV injection in this situation is very likely. And this is why ID block is preferred to lingual anesthesia, because ID block is much safer. There's less of a chance that you're going to unintentionally put it into the patient's veins, and it's just much better preferred, yani, in this case, because of this cardiotoxicity, especially by bupivacaine, which you can see right over here. The fourth reason behind a high plasma level is a slow metabolism, right? For example, someone with hepatic dysfunction, old patients. All of these things will reduce the metabolism of the local anesthetics, which will lead to higher amounts, which will stay in the body for a longer time, and they will cause toxicity. Or a slow elimination, for example, renal failure patients, where the metabolites or the drug itself stay in the body for a long time. But these are the reasons why we have a toxicity in local anesthetics. So let's talk about dosage instructions. How much of the specific local anesthetic are you supposed to give your patients? It's important to understand that most of the calculations we'll be doing will be based on the weight of the patient. يعني انت كل, you know that people are, we're different sizes, we're different weights. So obviously you can't give every single person the same dose. Because of the difference in weight, you have to adjust the dose accordingly. For most of the time, we're going to talk about milligrams per kilogram of body weight or milligrams per pound of body weight, depending on where you live. يعني some regions use kilogram, others use pound. But you're going to hear this a lot, this milligram per kilogram. لأنه إحنا زي ما حكينا إحنا بنحسبها على كل كيلوغرام من وزن البني آدم. Okay, this will allow us to give a better dose to the patient suited to their own body weight. Now, let's talk about instructions. For healthy adults, the average weight is either 150 pounds or more. 150 رطل اللي هي تقريبا 70 kilo. That's the average weight of a healthy adult. Obviously, there is some variation. For example, this gentleman right over here, he's tall, so you can expect his weight to be 180 pounds or 190 pounds. Whereas this lady right over here is a little short, so she might be around 140. ولكن it's important to understand, even though there's variety between healthy adults, we consider 150 pounds to be the weight for every healthy adult, regardless of their actual weight. It's important to understand this. تمام؟ يعني لو البيشنت كان healthy adult وكان وزنه 160 pound, I will give the patient the dose of a 150 pound patient. إذا كان وزنه 190 pounds, I will give the patient a dose of a 150 pound patient. فزي ما حكينا, you consider 150 pounds as the weight for every healthy adult regardless of their actual weight. لأنه most of the time they're going to be very close to 150 pounds. And the reason why we do this is because if you go beyond 150 pounds, the doses become higher and higher, and this can become unsafe for the patient. Some patients are obese, some patients have a weight of 200 pounds, 250. ما بدنا نعطيهم جرعات على وزنهم لأنه these doses are still very large and they can cause systemic toxicity. فعشان هيك 150 pounds is the safe margin that we consider for healthy adults. Now we calculate the maximum recommended dose using 150 pounds as the weight. زي ما حكينا for every healthy adult. Okay, I hope that was clear. So we talked about healthy adults, and we said that we calculate the dosage, we consider 150 pounds to be their weight, regardless of what their weight is, right? 150 pounds is the general guideline. It's the healthiest guideline that we use. Now, there needs to be precise calculation of the maximum recommended dose for elderly patients and children. This is very important, and you might be wondering why these specific populations of people. For elderly patients, we need to be very careful in calculating the dose because most of them have hepatic or some renal problems or cardiovascular problems, which will therefore make them more susceptible to toxicity by the local anesthetic, which means that for these patients, it's important to stay well below the maximum recommended dose. The maximum recommended dose is a guideline that we use to administer an effective dose to the patient that is still safe. We should never go beyond or above the maximum recommended dose. تمام؟ يعني أكثر منها ممنوع لأنه it will become unsafe. ولكن بالنسبة للelderly we have to stay below the maximum recommended dose. مع إنها MRD مفروض تكون آمنة, we still have to be careful and cautious لأنه these patients زي ما حكينا they are special, so we have to stay below the maximum recommended dose. For children, the reason why we need to calculate the maximum recommended dose for them is because there's a variety in weight. على عكس الهيلثي adults اللي هم تقريبا كل وزنهم بيكون نفس الاشي ما بين ال 60 كيلو لل 70 كيلو لل 80 كيلو. Children are very, very variable in their weight, right? You can have some children that are, 10 kilograms in weight, and you can have some children that are 30, some children that are 50. For that reason, the maximum recommended dose has to be calculated for each child based on their own weight. There is no guideline for children. لازم تحسب maximum recommended dose لكل طفل على حسب وزنه هو. تمام؟ على عكس الادلتس اللي احنا كنا ناخذ ال 150 باوند اللي هو الستاندرد. Okay? So let's calculate the safe dose. Let's do some actual math. So it's important to understand here that cartridges contain 1.8 milliliters of the solution, something we've already discussed. Here's what the cartridges look like, or the carpools يعني. هسا as a physician you have to know how many cartridges you can give to a patient. احنا بالتطبيق العملي ما راح نحكي والله بدي اعطي البيشنت 20 ملغ ولا 25 ملغ، لا احنا بنحكي بدي اعطي البيشنت كربوله واحده او كربولتين او 3 كربولات. هيك احنا بنحكي باللوكال انستيزيا. ف you have to calculate how many cartridges you can give safely to a patient. Before we do anything, أول إشي we have to calculate the concentration of local anesthetic in the cartridge formulation. شو يعني هذا الحكي؟ الكربولة نفسها راح تلاقي مكتوب عليها إشي زي 2% lidocaine أو 3% mepivacaine أو 4% articaine. فأنت من هاي البرسنتج بدك تحسب الكونسنتريشن. شو يعني concentration؟ يعني كم ملغرام of the drug I have in 1 milliliter of the solution. تمام؟ So for example, when I say 2% lidocaine, this means that I have 2 grams of lidocaine per 100 milliliter of solution. هسا ال 2 grams هذول قديش بيساووا بالمليغرام؟ They're equal to 2000 milligrams. صح ولا لا؟ Which means إنه this same equation اللي هي 2% lidocaine is equal to 2000 milligrams على 100 milliliters. أنا ما عملت شيء، أنا بس هاي ال 2 grams خليتها 2000 milligrams which are equal يعني. Then I can do some division. الزيرو بتروح مع الزيرو مع الزيرو مع الزيرو، فبيضل عندنا 20 milligrams per milliliter. يعني for 2% lidocaine cartridges, I have 20 milligrams of lidocaine for every 1 milliliter of solution. Another example, 3% mepivacaine. So here we have 3 grams of mepivacaine for every 100 milliliters of solution. Again, 3 grams راح تصير 3000 milligrams. اقسمها على 100 milliliter. Remove the zeros. You're going to get 30 milligrams for every milliliter of solution. Okay? This is very important لأن هاي الخطوة البدائية عشان نحسب maximum recommended dose للpatient. Okay? So let's actually start calculating, my friends. Practice question. How many cartridges of lidocaine 2% with epinephrine 1 to 100,000 can be safely administered to a child of 25 pounds of weight? Note the maximum recommended dose in milligrams per pound equals 3.2. تمام? So again, they gave us the maximum recommended dose, which is 3.2 milligrams per pound. يعني لكل رطل من وزن الطفل لازم أعطي 3.2 milligrams. These are the information that they gave us. Step 1 is calculating the maximum recommended dose in milligrams for our patient. البيشنت تبعنا وزنه 25 pound. تمام؟ بدي احسب له الجرعه الماكسيمم recommended dose. كيف بدي احسبها؟ بستخدم هاي الجايد لاين اللي هي 3.2 milligrams per pound of body weight وبضربها في وزنه اللي هو 25 pounds. الباوند رح يروح مع الباوند بضل معنا المليغرامز و 3.2 times 25 will give us 80 milligrams. يعني الجرعة القصوى اللي بقدر أعطيها لهذا الطفل عبارة عن 80 milligrams. طب هذول ال 80 milligrams قديش بيطلعوا in milliliters of solution؟ هذا اللي بدي أعرفه أنا. So the formulation here is lidocaine 2%, صح؟ 2% lidocaine زي ما شفنا قبل شوي is 20 milligrams per milliliter. فهسه أنا بدي أحسب ال 80 ملغرام هذول قديش بيطلعوا بالمليلتر، فبروح بقسم 80 على 20 زي ما أنتم شايفين هون 80 milligrams divided by 20 milligrams per milliliter. الملغرام بيروح مع الملغرام، المليلتر بتطلع لفوق بضل عندنا 4 مليلتر. So the maximum recommended dose for this child is 4 milliliters. هسه I calculate the number of cartridges. ال4 مليلتر هذول قديش بيطلعوا معي بالكارتريج؟ بيقول لك والله I have 1.8 milliliters per cartridge. فرح أقسم 4 مليلتر على 1.8. اللتر ما حتروح عفوا المليلتر راح تروح مع المليلتر، الكارتريج راح تطلع لفوق فبضل عندنا 2.2 cartridges as you can see. This is the maximum recommended dose that I can give to this child, okay? So here we can see a table showing us the different drugs, different formulations as you can see, 2%, 3%, 4%, 0.5%. And it's also showing us the calculations that we did, the milligrams per milliliter, the milligrams per cartridge, maximum recommended dose, maximum recommended dose in milligrams, etc., etc. So let's take an example of lidocaine, right? Lidocaine 2% plain يعني ما معها epinephrine, okay? So if we're talking 2%, this means the concentration is 20 milligrams per milliliter, something we already know. هسا when we talk about the milligrams per cartridge، الكارتريج الوحدة قديش فيها 1.8 مليلتر، فإذا بدي أعرف الكارتريج كم فيها مليغرام راح أضرب 20 milligrams per milliliter multiplied by 1.8 milliliters، فهيك راح يضل معي 36 milligrams per cartridge, okay? Now the maximum recommended dose in milligrams per pound is 2. يعني I have to give 2 milligrams for every pound of body weight for the patient. فإذا بعتبر إنه البيشنت تبعي وزنه 150 باوند وبدي أحسب له الماكسيمم recommended dose in milligrams، بروح بضرب 2 ب 150 باوند، الباوند بتروح مع الباوند فبضل معنا مين؟ 300 ملغرام. And you can do the same for all the rest. Okay? So let's talk about some local reactions from the local anesthetics. يعني الirritation اللي بتصير محل ما بنحط الانستيزيا شو ممكن يصير؟ بنقول لك أول شيء the direct trauma from the needle or the volume of the solution injected. يعني أنت لما تغز المريض بقوة شوي if you apply some trauma or if the volume of the solution is a little bit high you can cause some damage and edema to the tissue. تمام؟ طبعا the dosage and the cytotoxic nature of the local anesthetic نفسه ممكن مثلا تعطيه concentration عالية شوي أو اللوكال anesthetic يكون بطبيعته cytotoxic فراح يعمل شوية edema، راح يعمل desquamation اللي هي the sloughing. You can see the sloughing over here which is basically the removal of the outer layers of the squamous epithelium. And of course, there's also the vasoconstrictor-induced ischemia and necrosis, something that we already touched on. Now, there's one possible side effect or local reaction from the local anesthetic, which is neurological deficit. If you remember when we talked about the peripheral nerve block, حكينا إنه لا يمكن نقرب النيدل على العصب. We have to never touch the needle with the main nerve trunk, because if we do, there's going to be nerve damage, and this is exactly what happens here. The neurological deficit results from trauma to the main nerve trunk. يعني إذا المخدر دخل الإبرة وظل يمشي تا وصل للعصب and they actually penetrated the nerve, this is where we have trauma to the main nerve trunk and this will cause neurological deficit. شو هي الديفيسيت بالضبط؟ راح يكون في عنا transient anesthesia أو paresthesia of the lip tongue and oral tissue اللي هي إذا عملناها مثلا بالأورال anesthesia، فراح يكون عنده البيشنت فقدان بالإحساس. they will have anesthesia أو they will have paresthesia اللي هي التنميل أو numbness in the lip, tongue and oral tissue. And this neurological deficit lasts for a very long time. It lasts 2 to 6 months. So as a professional, you have to make sure that you never touch the main nerve trunk when you are anesthetizing the patient. The hypersensitivity reaction is something we already touched on, especially for the ester type local anesthetics because of the production of the PABA or para-aminobenzoic acid. We followed this progression of symptoms. Another thing that can cause hypersensitivity is the preservatives and the bisulfites. These can also actually cause hypersensitivity when we give the patient a local anesthetic with a epinephrine. The symptoms of course are classical hypersensitivity like pruritus اللي هي الحكة، erythema اللي هي الاحمرار، rash راح يكون في عندنا طفح جلدي، urticaria، angioedema اللي هو الانتفاخ، wheezing اللي هو صوت الصفير لما البني آدم يتنفس، asthma اللي هو مش عارف يتنفس، and anaphylaxis which is basically the generalized hypotensive shock وغيره. So what are some systemic reactions of local anesthetics؟ يعني إذا local anesthetic وصل على systemic circulation in high enough concentrations شو ممكن يعمل للبني آدم؟ بقول لك بالنسبة للcentral nervous system it can cause drowsiness, unconsciousness, respiratory depression, respiratory arrest, nausea, vomiting, and this makes sense because the local anesthetics they inhibit neuronal action potentials, which means that they generally depress the central nervous system. That's why they cause drowsiness, that's why they cause unconsciousness, that's why they cause respiratory depression and arrest. So that kind of makes sense. Now for the cardiovascular system, they can cause bradycardia, they can cause hypotension, they can cause ventricular arrhythmias. Again, kind of makes sense. They are depressants, they inhibit neuronal or they block sodium channels which are necessary in the pumping of the heart and the tone of the blood vessels. So yeah, it kind of makes sense. So let's talk about sympathetic reactions. And when I say sympathetic reactions, I'm talking about the local anesthetics that are with vasoconstrictors. We know that the vasoconstrictor is an adrenergic agonist, usually it's epinephrine, which means that it's going to cause an increase in the adrenergic tone. It's going to cause an adrenergic stimulation. This can be dangerous for many patients. For example, if patients are hypertensive, if they have a blood pressure of over 180/110, we cannot give the patient this kind of formulation. ما بنقدر نعطيه local anesthetic مع vasoconstricting agent. Or if the patient has any other kind of cerebrovascular disease, for example, a recent MI, angina pectoris, if they have arrhythmias, symptomatic ventricular arrhythmias, AV block, uncontrolled hyperthyroidism, كل هاي الأمراض ما بتسمح لنا نستخدم الفازوكونستريكتور مع اللوكال anesthetic. Now we have to be very cautious. Most of the time we try to avoid, ولكن you can still give it ولكن be cautious. Okay, be very very cautious. ولكن المحبذ إنك ما تعطيهم هاي الformulations. It's better to go with the plain anesthesia. Okay. Now, what about local anesthetics and pregnancy? This is very important because a lot of pregnant ladies have to have operations. فبدنا نعرف إذا بنقدر نعطيهم local anesthesia. Now, it's important to understand there is no firm evidence that any local anesthetic is teratogenic in humans. يعني ما عنا أي نوع من الأدلة الصلبة اللي بتحكي لنا إنه local anesthetics بتشوه الجنين. Okay? ولكن كنوع من الاحتياط we try to postpone any medical procedures requiring local anesthesia from the first trimester واللي هو أول 3 شهور من الحمل if the condition can be delayed to the second trimester واللي هو من الشهر الرابع للسادس. تمام؟ لأنه عادة إحنا بأول 3 شهور من الحمل we try to avoid giving the pregnant lady any kind of drug لأنه this is a very important time of development ف we don't want to risk it. فعشان هيك if there is any procedures we try to delay it to the second trimester. Now, lidocaine and the prilocaine are classified as Class B FDA medications. Or Class B FDA medications, this means that they should not be administered during the first trimester of pregnancy, ولكن they can be administered in the second trimester. تمام؟ A Class B معناها إنه the drug itself has some studies in animals showing that it is not teratogenic ولكن ما في دراسات على البشر. فthis means انه اوكي دراسات الحيوانات بتحكي لنا انها ما إلها تشويه على الجنين، ولكن احنا هاي الاشياء برضه ممكن ما تطبق على البشر، ف we have to be a little bit more careful. فعشان هيك in the first trimester we avoid giving these drugs وبنستنى للsecond trimester. هسا Mepivacaine, Articaine and Bupivacaine, these are Class C FDA medications. Or Class C means that animal studies have shown that these medications are indeed teratogenic, ولكن there are no human studies. فبما انه في عنا ادله من الحيوانات انه بالفعل هاي فيها إلها تشويه على الجنين، وقتها احنا خلص we stay on the safe side and we don't give these drugs at all during pregnancy، لا بالفirst trimester ولا بالsecond trimester ولا بعده. اوكي especially Mepivacaine should not be used in obstetric anesthesia. يعني مثلا بالcesarean section الولادة القيصرية we don't give Mepivacaine especially لأنه it has an increased toxicity to the neonate. Okay, so these medications are class C medications, which means that they have been shown to cause teratogenicity in animals with no studies in humans, so we stay on the safe side and we don't give them at all. Okay, على عكس class B medications where the animal studies do not show any teratogenicity, ولكن for these medications we still be safe and we give them in the second trimester. Now, when it comes to epinephrine, is it safe to give pregnant ladies local anesthesia with epinephrine? بقول لك yes, as long as the dose stays below 0.1 milligrams, there is no effect on labor or on the uterus or on the fetal circulation. فالأمور طيبة. Here are the FDA categories. Category A زي ما حكينا اللي هو بيكون في عنا adequate and well-controlled studies على البني آدمين that fail to demonstrate a risk to the fetus in the first trimester of pregnancy. يعني بيكون عاملين دراسات على البشر، على السيدات الحوامل، وأثبتنا إنه ما في إلها أي خطر على الجنين. These are perfectly safe to use. Category B زي ما حكينا we only have animal reproduction studies which have failed to demonstrate a risk to the fetus. يعني there hasn't been any teratogenicity shown in animals، ولكن with no studies in humans. In category C زي ما حكينا the animal reproduction studies have shown teratogenicity with no studies in humans، فعشان هيك احنا we stay on the safe side and contraindicate them altogether for pregnant women. What about local anesthesia and breastfeeding? بيقول لك إنه specifically bupivacaine, which we said causes cardiotoxicity that بتتذكروا, bupivacaine is actually excreted in human breast milk. So this causes potential serious toxicity in nursing infants. فعشان هيك we don't give it to lactating ladies لأنه this can cause potential toxicity to the nursing infant. What about drug-drug interactions? We know that the local anesthetics will eventually make their way into the systemic circulation and they will be metabolized by the liver. ولكن can they interact with any other drugs the patient is taking? Yes. For example, the local anesthetics, because they have a depressive effect. Why do they have a depressive effect? Because they block the action potential زي ما حكينا. We should not give them with CNS depressants زي sedatives والopioids وخلافه. تمام؟ Because again, this is going to cause a drug-drug interaction وهي الأدوية حتتفاعل مع بعضها and it will cause a great depression of the central nervous system. Also, local anesthetics with vasoconstrictors زي الابinephrine should be avoided if the patients are taking monoamine oxidase inhibitors, tricyclic antidepressants, ergo-type drugs, non-selective beta-1 adrenergic receptor blockers, thyroid hormones, and some general anesthetics. The reason why is because if you give these medications with the local anesthetic and vasoconstrictor, there can be severe prolonged hypertension, cerebrovascular accidents, and cardiac arrhythmias. So, things that you definitely don't want to happen. So, let's say that your patient has undergone an operation, you performed local anesthesia, the operation is over, ولكن the patient is still numb, they still have numbness, لساته مخدر. فمنزعج الشغلة بيقول لك لا I want this anesthesia to be gone. فthis is how we reverse local anesthesia. بعد ما نخلص العملية إذا كان لسه البيشنت مخدر we can give them a drug to reverse this local anesthesia. فزي ما حكينا if the operation ended but the numbness remains we can give this drug to reverse the local anesthesia. How do you reverse it? Well, you speed up the absorption of the local anesthetic into the circulation. The reason why the patient is still anesthetized is because the drug is still active in the tissue in which you administered. If you want to reverse this local anesthesia, you simply increase the blood flow, remove it from that area, and send it into the bloodstream. فهاو do you speed up absorption? You increase the blood flow by vasodilating the area. You use a vasodilator such as phentolamine mesylate, which you can see right over here is called Oroverse. تمام? This phentolamine mesylate is a non-selective alpha blocker, and it specifically acts and causes vasodilation via alpha-1 blocking. فلما تعمل vasodilation, this will increase the blood flow to the area, it will increase the absorption of the local anesthetic, فهيك راح يكون يطلع من المنطقة اللي هو شغال فيها, and this will lead to reversal of local anesthesia, والpatient راح يرجع يسترجع الإحساس بهاي المنطقة. That is the end of our presentation. I hope you enjoyed this lecture. I apologize if it is a little bit long, and if you guys have any questions, please make sure you let me know. And yeah, peace.